So welcome to Deborah International webinar sessions. The webinar today is on pregnancy, childbirth, and aftercare in Epidermolysis bullosa clinical practice guidelines, which was published in October 2021. It is my great pleasure to introduce to you Dr. Danielle Grimblad. She's a consultant dermatologist based at Guy's and St Thomas's Hospital Trust in London, UK. She's a clinical lead for pediatric dermatology at St Thomas's and is an honorary senior lecturer at King's College London. Danielle's first developed an interest in epidermolysis bullosa during her fellowship training in pediatrics and genetic dermatology. She is now co-leads the clinical arm of the National Commissioning Service for Adults with Epidermolysis bullosa in London, and works as part of a diverse multidisciplinary team to deliver patient care. Thank you, Danielle.
So thank you very much for that lovely introduction, and I will now start to share my screen, which hopefully does work. And I think it looks good. Is that right, Katja?
Looks perfect.
Perfect. Okay. So we are, as Katja has introduced, we're going to be taking a whirlwind tour through these guidelines for pregnancy, childbirth, and aftercare in EB. So really a little bit of background, firstly, to say that, of course, the decision to start a family is very personal and unique for every individual. And women who live with rare disease, we feel, should be absolutely supported in their choices and be able to access the reliable clinical guidance when this is needed. And there has been sort of an increased focus on this recently, because there's been better earlier access to diagnosis and maybe better management of genetic disease overall in recent decades. And there's been a lot of improvement in access to prenatal diagnostics too. More women with rare genetic disorders are actually reaching reproductive age and are then able to make informed choices. So we wanted to view this through the prism of EB. Unfortunately, there is very little evidence for pregnancy and childbirth management in EB available within the medical literature prior to our starting this. So our question was really, how do we provide good practical information to women with EB? And then we looked at what we already knew. We did know that pregnancies had been reported in women with all different subtypes of EB. And we know that EB, as a background, there are many different subtypes of EB. There's a lot of variability clinically, both between and even within subtypes of EB. But there wasn't any prospective data that we could really look at. So how things unfolded. In 2018, Deborah International consulted the EB community, and they identified this high priority area for development of a guideline within this domain: pregnancy, childbirth, and aftercare. And we were very fortunate to be able to secure sponsorship through Deborah International and Deborah UK. And Katja sent to work convening a CPG group, which consisted of 16 members from 7 different countries. And it was a really lovely group of people, not only lovely, but also different sorts of expertise. We had dermatologists, nurse specialists, both within EB and neonatal EB. We had midwives, obstetrics, patient representatives. So it was really across the board. We started out by doing a survey, which we sent out to patients with EB and also their carers. Later, also healthcare providers, and this was sent out via our Deborah International newsletter. And then we convened our primary panel meeting in 2018. And this was set in the beautiful surroundings of Zermatt, which was at a conference, and you can see us there looking. This is pre-COVID. We were all looking very optimistic, and perhaps the setting had something to do with it. But we, at this meeting, were able to identify the aims of our project, which was really to improve the effectiveness and quality of pregnancy and childbirth care for women of reproductive age with EB. We wanted to try and decrease the variation in practice internationally. So this really, the intention was that this would be a guideline for international use. And then to be able to provide evidence-informed recommendations so that in future we could actually have standards and benchmarks against which we can practice. And then finally, were there things that perhaps we could identify as future quality improvement initiatives which we could link up with the CPG? So firstly, in any guideline development, we have to really consider our clinical questions very carefully. We look at the patients, we look at the intervention, we try and compare and look at outcomes. And we try to do this within different domains. So firstly, we thought about the preconception and antenatal management domain, and then labor and management of delivery, and finally postnatal care and management. As I mentioned earlier, we wanted this really to be a very practical and clinically driven guideline, and therefore we wanted it to follow the natural trajectory of what women would be going through when they start thinking about a pregnancy, and how do they start planning through to actually, being pregnant, delivering the baby, and all the postnatal care which should follow. So the next step was that we performed a literature review, and initially we identified 415 records. And as you can see, going through this flow chart, ultimately we were left with only 22 papers which we could include in the qualitative synthesis of the work. And of these, 18 were either case studies or small case series. There was one larger sort of survey which was published, and that gave us quite useful information. You will note that that doesn't quite tally up to 22, and that's because a few of our papers were actually just conference abstracts which had been published, but that's really because, as you can tell, there was no randomized prospective data that we could really use. So the actual evidence base was sparse, and this is not uncommon in rare disease. We also bolstered this up with guideline documents, of which we had 8. 6 of these were purely EB related, and a further 2 were related to obstetric management. So that was also very helpful and informative for us. And then we had an appraisal stage. During this stage, we had 2 independent appraisers who went through all of these papers and assessed them for quality. And we then convened our second panel meeting. This was at EB 2020, which was a conference in London. And we were able to really start to put forward our key recommendation summary based on that, those sort of 3 domains that I'd mentioned earlier. And then we had to really put our thinking caps on and start preparing our documents. And what happened through this process was that we were able to put together initially 18 key recommendations, which fell within the preconception and antenatal management domain. We had a further set which were related specifically to labor and management of delivery, and finally a few at the end relating to postnatal care and management. So I'm going to start just going in through the sort of meaty bits of our recommendations. And obviously what I haven't been able to do just for the purposes of this webinar is really go through all the detail about how we used the evidence to weigh up the strength of our recommendations, but this was quite a difficult process, and we used the grade methodology, which was complex within this area because of our limited evidence and data that we had. But in terms of the preconception phase, first recommendation says that we should discuss and evaluate the vulval and vaginal manifestations of EB when we see patients, and dependent on the subtype, really as part of routine care. So it really should be, as we ask about the skin, we ask about the oral mucosa and various other parts, depending on the patient's EB subtype. We should also have as a point in our minds when we evaluate patients, what about vulval and vaginal manifestations? Because I think very often this can be potentially overlooked. And there may be women who have some types of dystrophic EB where there is vaginal stenosis or difficulty or pain during sexual intercourse. And so it would be absolutely the right thing to consider referral to an assisted conception unit if women are struggling. The next thing we thought about was that standard preconception care and access to genetic counselling should be provided where it is available. And you can see that the way that we've worded things and the language we've used is really taking into account the international setting, that not everything that is available in my setting where I work is going to be available for another person in another country on another continent. And we're very mindful about that. So these are obviously gold standard recommendations, but it will depend on where people work. But at least this does provide a document which does set that out. Now, depending on the inheritance pattern, the risk assessment for the pregnancy can actually be estimated very often clinically, and then prenatal testing may be offered. So couples who are at risk of severe forms of EB in the offspring may be offered potentially pre-implantation genetic testing or prenatal testing. And of course, we made note of the fact that that would also depend on what the couple's viewpoints are and how they feel about undertaking those investigations. That would never be forced onto anybody, but patients and families should be able to access that if they feel that they would like to. Now, carrier screening is a bit of a grey area. Not everywhere does it, understandably, if the partner is unaffected and unrelated, but there may be individual situations or different national regulations where this is available and offered. Sorry, I just mentioned the fact that we used quite a lot of the guideline for lab diagnosis of EB in informing this particular recommendation. So what about optimizing health pre-pregnancy? Well, we said mainly that we should be following standard preconception care guidelines, just as we would any other woman. But in particular, just really think about all of those vitamin areas, folate, iron, vitamin D, supplementing zinc and selenium if needed. Women with EB may be slightly more prone to having low iron levels, for example, depending on their subtype. So we have to perhaps be a bit more mindful about the comorbidities that women with EB may have. And we also suggested that in R4 that we are very active in managing severe anemia, chronic infection, poor nutrition, and oral health in women with severe subtypes of EB who will potentially be prone to these conditions. And we also noted that some women with EB may actually have gingivitis and oral ulcers even preceding pregnancy, and that unfortunately the pregnancy state, because of hormonal fluctuation, may exacerbate this. We then said that just a note about medication review. Many women who have severe subtypes of EB will be on chronic medicines such as analgesia, opiates, even proton pump inhibitors. So as a good practice point, we said, please to review all the prescription and over-the-counter medicines and supplements in the context of a woman who is either pregnant or planning a pregnancy. And I mean, this stuff is kind of, perhaps just normal clinical care. And yes, it is, but we, as developing this document, we felt it was important to highlight these things. Also, drugs, of course, should only be prescribed in pregnancy if there is an anticipated benefit to the mother with EB, and that benefit outweighs the risk to the fetus. And where possible, anything that's non-essential should be avoided, particularly in the first trimester. Now, we spoke about the physiological changes in pregnancy, the fact that in early pregnancy, the levels of human chorionic gonadotrophin start to rise, and this causes an increase in gastric acidity, and there'll be a relaxation of esophageal sphincter tone. There may be abdominal bloating and constipation, and all of these factors can make the state of EB a little bit worse, because we know that women with EB may have pre-existing reflux disease. They may have pre-existing esophageal strictures related to their EB. So if they then get pregnancy-related nausea and vomiting on top of that, it can be a very serious situation. We did say that if we do need some kind of anti-secretory treatment or mucosal protection, then of course, please choose only agents which are safe in pregnancy, and just to beware of ranitidine, which historically was used quite a lot, but now has been recalled. So the next thing in R7, we said that constipation we know is a problem in women with EB, and important to make sure that women are well hydrated, that they're trying, exercise and non-pharmacological measures, modifying the diet appropriately. Just be aware of iron supplements, which may exacerbate constipation, and sometimes we need to treat things medically. Now, in terms of the actual pregnancy itself and how that impacts on wounds, well, most of the evidence seemed to show that the expanding abdomen didn't necessarily worsen the abdominal wounds for women with EB, but of course it should be monitored. And we said about antenatal visits that, especially for women who have complex forms of EB, dystrophic forms or junctional severe forms, it's important that we have an MDT approach. And this can involve, dermatologists and nurse specialists and the obstetrician, and having people really talking to each other is the best for the individual patient. And particularly when a child with EB is expected, perhaps because it's a dominant form of EB or because there is prenatal testing that has been done, it's important that we engage with the neonatal team and pediatric EB nurse as soon as possible. And that, as is pointed out here, should be done antenatally. So what about standard investigations that take place at antenatal visits? Well, should we be doing blood pressure? How do we manage this individual? All of the standard things should be done as per usual, but we've just suggested some modifications, how to use a BP cuff in EB, how to, put on padding and using non-adhesive tape. And we've also made some discussion about ultrasounds and how this can actually be done very safely. But lubrication is very important, how much pressure is very important, small probe size are very important, and we've laid that out very carefully. Also, during antenatal visits, often the fundal height is examined, and it's just important that this is done in as gentle a manner as possible and using lubricants or sometimes non-adherent film, which can help to reduce friction on the skin. When speculum or vaginal examination is needed, again, generous lubrication. So we have a secondary document which we've added, which is a lovely way and kind of quite a visual way of just showing patients, this is in the supplementary material which will be published, about how things can be applied. So you can see here we've got some soft band sitting underneath the blood pressure cuff, and this is a way of reducing friction on the skin, and some Mepitel one here. So what about anaesthetic assessment? Well, you might think, why are we thinking about that antenatally? Because preparation is everything. We want, women to really be able to access the best kind of care during the labor itself. So we want women to have information so that they can actually understand and think about how they want to deliver their baby. It should be women-centered care. So women should be in the driving seat for that and should be really encouraged to prepare a birth plan together with discussion with their obstetrics consultant or their midwife, and also taking into account their EB needs. We also said that providing care antenatally is ideal if it's done nearer to home. And this is really important because this means that that person's support network is around for them. So we don't want to sort of have to ship that person miles away from home for the delivery because it may be that that's not feasible in an emergency, or that, it's just really inconvenient. We have to individualize the approach. What are the risks to the mother and the baby? We also have stipulated that EB itself is not a contraindication to vaginal birth, but there may be certain strong maternal preferences. For example, if a woman is extremely worried about having a delivery vaginally, if she's got very bad wounds or difficult scarring in this area, there may be alternative considerations, but having EB is not a contraindication per se. So it should, in fact, on the balance of risk and benefit analysis, we felt that vaginal birth should be offered as the preferred mode of delivery for women with all subtypes of EB. But there are some exceptions. So avoiding vaginal birth is important if there's any routine obstetric indication for C-section, if there's a lot of EB blistering or vaginal stenosis, or if the baby is in a breech presentation. We wouldn't want to be suggesting an external cephalic version, which is where they turn the baby in the womb, because that does require quite a lot of force and friction on the skin. We also spoke a little bit about the fact that there isn't much evidence in the literature for vaginal birth increasing the risk of subsequent vaginal scarring or stenosis. In fact, there was evidence in the literature that women, even with severe subtypes of EB who'd had a baby, had gone on to have another baby, suggesting that there is patency of the canal. We said about the fact that dominant forms of EB, there's a 50% chance of having a baby affected with EB for each and every pregnancy, despite this vaginal delivery is still preferred, but to engage the neonatal team early on. And anaesthetic assessment is important in women who have a difficult airway, or they've got small mouth opening, or very difficult wounds around the lower back. And this is because it would potentially be difficult or challenging to get a spinal in for their anaesthetic, and also if there is a chronic pain issue. So what about longer term planning? I'm aware of the time, so I'm going to try and get my skates on. We thought that it's important in the antenatal period already to actually start thinking about what happens when the mum goes home. You know, what's the hand function like? Is mum going to be able to put a bottle of formula together? Should that be her choice? Does she need any additional support for going home? And start to think about that antenatally. We spoke about the need for ongoing EB skin monitoring throughout the pregnancy. Just because this patient is now pregnant doesn't mean we can forget about other potential risks, for example, EB-related SCC in severe subtypes. And then we started to look at the labor and management of delivery. We spoke about a dressings pack, and that this should be prepared in advance for a woman who is going to deliver a baby, having things which are not adherent, and a medical adhesive removal spray, which can be accessible and there ready for the labor, both for mum and for the baby potentially. We said that women should have handheld notes. This should have some information about the subtype of EB, the delivery plan, and also the contact details for the EB specialist team. We spoke about, again, early access to the neonatal team in case a baby is going to be affected, and the management of the neonate in that early phase. We didn't go into this in depth because there is a separate neonatal guideline, but we did make note of the fact that, you know, how to handle a baby, vigorous rubbing to be avoided, and how to suction if oropharyngeal suction is needed. Again, management during labor and delivery, just very gentle abdominal examination. We spoke about CTG belts, the fact that they can cause friction and blistering, but that, again, padding may be helpful for underneath, similar to the blood pressure cuff. If vaginal examination is needed, just the importance of good lubrication, and avoidance of fetal scalp electrodes if we don't know what the baby's status is. Then we laid out some specific skincare adaptations which should be offered during birth and labor. So this includes things like the CTG machine and how to use stirrups, avoidance of prolonged pressure or immobility, really to encourage the woman as much as possible to self-position, to mobilize if she is able to, and to encourage independent movement. We spoke about table padding, and making sure that that's smooth so we don't get ripples and things which can, you know, worsen blistering. And also about how to use an ECG electrode and how to do that. And again, in our supplementary document, we've shown how to cut out the dots and put it onto some non-adherent Mepitac tape, how to secure skin during stirrup use, for example, as well. So we've spoken about that with pressure relief. There are some adaptations in addition to position change, things like inflatable mattresses and pillows, which can be helpful. The importance of trying to keep the labor room cool because sweating can worsen, sometimes blistering. Sometimes if it's overcooled and there's lots of aircon on, that can be bad for a patient's eyes. So just to be mindful about that. We discuss catheterization, of course, to avoid it unless it's absolutely necessary. But if it is needed, to use the smallest possible silicone urinary catheter, and this should be very well lubricated. We went into how to secure IV lines and how to cannulate. And then we also mentioned about the fact that some women who have EB will be already on analgesia, so we do need to think about how to deliver the anaesthetic and how to give analgesia itself. So there may be specific changes if we're using Entonox, how to lubricate the mouthpiece and secure the epidural. For anaesthetic management, we recommended that if a cesarean section was planned, to try for regional anaesthesia, which is either a spinal or epidural rather than anything else. and that there were some sort of skin preparation recommendations which we suggested. But if a general anaesthetic was needed for whatever reason, we've got some specific recommendations about how to handle that situation. Of course, we know that women may be more at risk of regurgitation or aspiration because of strictures in the esophagus. There might be a difficult airway. We've spoken about that before. And I guess this is important because it highlights the need for that antenatal anaesthetic assessment. Induction of labor is not contraindicated, but that we've also spoken about how to do that and trying to avoid vaginal trauma if induction of labor is being done with vaginal pessaries or needing speculum, VEs, etc., rupturing membranes. We had some comments back and added this about birth setting, that hydrotherapy and water birth may be considered, and home birth, although it may be feasible, we felt should not be considered if there was a risk of an affected neonate. With regards to instrumental delivery, we thought that this is probably best to avoid, both to minimize skin trauma and also to the mum, but also to the potentially affected neonate. Cesarean section, we spoke about minimizing handling during transfer, avoiding rolling or sliding devices, and considering bipolar diathermy or the harmonic scalpel. But if monopolar was needed, then to definitely use medical adhesive removal sprays to remove those adhesive pads. For episiotomies and tears, the evidence is actually they heal very nicely in EB. So if there was one that was, if a episiotomy was needed for an obstetric indication, well, that's absolutely fine and they can be managed in the usual way. With regards to antithromboembolism management, we tend to suggest avoiding compression stockings because of friction caused by putting them on and taking them off. Flowtron boots occasionally can be used provided that they are well padded. And then we recommended mother-infant bonding and skin-to-skin contact wherever possible. So just a few more. This is now heading to the postnatal section. We spoke about perineal care, the fact that postpartum vaginal discharge can be ongoing for a few weeks, and so to advise on soft sanitary wear. We spoke about the episiotomies, which heal quite well. Standard obstetric management, including sutures, are fine. And the importance of preventing constipation until the perineal healing is complete. What about care of the C-section wound? Just to really use non-adherent dressings and medical adhesive remover sprays. And to prevent thrombosis, again, in the postpartum period when that's necessary, if needed, a woman can be given low molecular weight heparin as per local guidelines. Now, infant feeding, well, we said this is really an individualized thing. So we have to think about the woman's subtype, what support structures she has, what the breasts are like, how's the skin there, how her pain is, what her hands are like. And this can all be taken into account to weigh up whether this will be a good idea for her. And we also said that, there can be support, there may be help with positioning the baby, latching. Some women have found nipple shields can be useful if they're very well lubricated, and perhaps considering involving a lactation consultant if available. So the decision to formula feed or mixed feed, really, again, very individually done and depends on what the woman's needs are. Does this patient have pseudosyndactyly? Can she actually prepare a formula? If she's trying to think about formula or mixed feeding, then we should also be thinking about that in the postnatal care plan. And when planning discharge, we need to think about what this woman is going to require in the community and at home. Does she need support from a community midwife or health visitor? Does she need any specific aids at home? And also, the postpartum period is quite a challenging period for any woman. So screening for mood disorders, reinforcing the support networks to be reinforced. Perhaps it would be helpful for her to link up with another mother with EB, and that can be a great source of support, even if it's online or a discussion or a telephone call. And then finally, we said, of course, if a baby has been born who has EB, then there are definitely additional planning considerations which are needed. So to conclude, we thought about, how this data and how this document would lead on to future research, we felt that it would be really useful at some point to try and set up some kind of registry so that we can actually really gather numbers and outcomes and see how women are having babies and families who have EB, how is this working in the real world? And also there's very little out there on psychological impact on families and, starting a family for a woman or family with EB. So just to conclude, huge thanks to Katja in particular, who's been a rock and has facilitated the development of these guidelines. Our thanks also to Olivia, Deborah International, Deborah UK, and my co-authors on the guideline. So I'd be delighted to take any questions now.
Thank you, Danielle. That was amazing. Do we have any questions coming up on the Q&A? Let's have a look. There's no questions so far.
Okay.
If you
Well, I've stumped you all.
Just at the end. Oh, we have a question coming through from Joseph. Can you see it there in the chat?
Yes, I can. Thank you. So it's a question about a question that came through to the EB Nurses Forum. Women with RDEB who is sexually active, does sexual activity accelerate SCC? That's a really good question. And I guess this relates to the fact that SCCs in EB don't seem to be similar to SCCs which affect the general population, which are obviously often UV induced. In EB-related SCCs, we do think that there is an element of chronic inflammation and trauma to the skin, which is the driving force. So I guess this relates to the concept of frictional forces and whether this may potentially damage or worsen inflammation in the skin, and can this accelerate SCC? So to my knowledge, we don't have a very high, we recently published some cases of EB SCC, and I am not aware of a higher incidence amongst sort of vulval SCCs. Is that the question, Jose? Just really to think about site in particular, or any other? Because I think that is not something that we found in terms of collecting this big group of patients, and I don't think it's been reported. I hope that is an answer, but I'm waiting to see if you're typing more, Jose.
Okay, we'll see if she responds. Yes.
Thank you. That is clear. Excellent.
Danielle, I have a question actually about the fathers and was there any sort of literature showing the input of the partnership, really, when you're planning a family? It's a partnership.
Yes, and I think that's such an important point, Katja. And to be honest, there isn't a lot of literature on that at all. And it's something that I think we felt quite strongly about as a group, that it is an underlooked at area perhaps. And so we tried in the language of the CPG to really make it an inclusive document. It's not only for women with EB, it's for perhaps male patients with EB, partners of women with EB, and to try and be as understanding of the dynamic between the couple and their wider family as possible. This is a document that's not exclusively for women, but is really absolutely also to support partners. And hopefully through this document, this will be a way for partners to be included and know how to advocate for their partners better. And it may be an area of future research. I think we highlighted the fact that psychological, there's a dearth of literature essentially in terms of psychology and the impact of having a family, how a pregnancy will impact on a woman and their families. So I think that it's definitely something that we would wish to be more inclusive about in future and think about when we plan future registry studies, etc.
Thank you, Danielle. Do we have any more coming through? I don't see any more. If any come through to us or they're emailed to us, I will send through to you. But that was amazing. Thank you so much.
Thank you, Katja. And thank you everyone for logging in, and nice to see you. Bye-bye.
Bye-bye. Thank you.
Thank you, Danielle.